and alopecia. Those sort of patients who tend to respond very well to hydroxychloroquine. And here's another example of a gentleman who had Rho-positive SCLE, and it's not an artifact of the slide, his skin really is yellow, because I used somebody who benefited from mepacrin and hydroxychloroquine combination very well indeed. The mepacrin has a yellow dye in it that sometimes comes out in the skin and gives you this sort of yellow pigmentation. Other strategies for cutaneous lupus, we've had very good experience, which we've written up now, looking at topical tacrolimus and pimecrolimus, which is very well tolerated and effective. So these are not steroid creams, they incorporate tacrolimus, and as you can see, this is an example for one of the images with our publications show that it is very, very effective when the usual creams and potions that the dermatologists use have failed. I've got no experience with clofazimine, but I thought I'd put this study in because it may be of use to you. This was a study from South America looking at patients with treatment-resistant cutaneous lupus, where they were using chloroquine routinely, and it was a randomized controlled trial looking at chloroquine versus clofazimine, and they did very well. In fact, 82% of them got benefit from clofazimine compared to 75%, and it was generally well tolerated, but I have no experience of clofazimine. Other strategies for severe cutaneous lupus, methotrexate in my experience works very well, and this is all experience. This is sort of evidence-based medicine as opposed to evidence-based medicine. Dermatologists and rheumatologists treating lupus use these drugs for treatment-resistant skin disease. Mycophenolate, in my experience, is not that good, especially for discoid lupus. Discoid lupus doesn't seem to respond very well to mycophenolate. Dapsone is used by the dermatologist, and retinoids can be extremely useful, but they're usually under dermatological supervision. Just a word about non-steroidal anti-inflammatory agents. The textbooks all say use non-steroidals. I don't use them at all. Absolutely not. Why don't I use them? As a rheumatologist, well, there's no trials of lupus. There's lots of side effects, and they actually don't treat lupus. And if you do use them, I use them very, very sparingly for a short period of time. The reason I don't use them is because of this problem, and especially relevant to the COX-2 selective agents, with the increased risk of cardiovascular disease. We know that Vioxx was withdrawn for this very reason, and this class of drugs is associated with this increased risk of cardiovascular events, myocardial infarctions and strokes. And you know, I haven't dwelt on it too much here, but we know that lupus itself is associated with a significant risk of accelerated atherosclerosis. So for these reasons alone, I avoid non-steroidals. And actually, hydroxychloroquine does the same job. Slower acting, but much better tolerated. Moving on then to lupus nephritis, a particular interest of mine. We know this is a serious complication. Cumulative prevalence, it's very common. Up to 3/4 of patients during their disease course may have renal involvement, and it is a predictor of poor outcome. This is some data from Ricard Severa's Eurolupus study of 1,000 patients with lupus followed for 10 years. So if you have lupus nephritis as entry into this cohort, you will do worse in terms of survival. So death, development of nephritis is associated with premature mortality. No surprises there. How do I identify high-risk patients? Well, the standard lab tests will help us. High levels of anti-double-stranded DNA antibodies, low complement C3/4, there is an increased risk of nephritis. We've shown, I take my slide out of time, other antibodies that are useful. Anti-C1q antibodies, we're beginning to use this more routinely. It's an expensive test, but it is a very, very good marker for lupus nephritis, as good as, perhaps if not better, than anti-double-stranded DNA antibodies. And in our hands, anti-SM antibodies do have a predictor, but the problem is the confounding factor here that SM antibodies are more common in women of black ancestry or African ancestry, and we know that African ancestry is associated more with lupus nephritis, so there may be a confounder there. We're enthusiastic renal biopsies. We will do a renal biopsy unless there's a strong contraindication to doing renal biopsy. Renal biopsies give you a lot of information about diagnosis, prognosis, activity, and damage. So what about treatment? We are fans of intravenous cyclophosphamide, and Eurolupus regimen has now entered clinical practice. This is a regimen